So this week, I remembered to record. This week is the second half of our child's experience of hospitalization. So continuing where we left off last week. We know there's all sorts of different types of healthcare delivery settings, and our role as a nurse may change depending on where we're practicing. So, whether we're inpatient or outpatient in a clinic or doing home health, our role might be a little bit different. We might have different responsibilities or schedules, but overall, our job is to create that positive atmosphere. When we're preparing a child for treatment or a procedure, we need to make sure that we're considering their developmental stages, all those milestones and needs that we learned about the first 2 weeks. So, when we're dealing with infants, we want to make sure that we keep the parents involved as much as possible so they have that person that they can trust there to support them. They might also need a security object uh, to help them get through this procedure. Our toddlers are going to be very similar. They'll be able to understand simple explanations of what's going on. We really want to encourage them to tell us when things hurt and when they're uncomfortable. Even if they're scared of getting medication, they still need to be able to express themselves to us. They should be able to follow simple directions, and we should allow them to make choices as much as possible. So even if it's something as simple as choosing what color band-aid or what color cast they want, giving them those opportunities is really important. They're easily comforted by distraction, so it's great if you have Child Life available to help you during a procedure. They do a really great job. And then making sure parents console them afterwards. For our school-age children, they're going to follow the same things that we do for infants and preschoolers, but we also need to give them opportunities to examine the equipment, let them play with things that aren't going to hurt them. We want to encourage them to verbalize their fears and make sure that we address anything that might not be quite right and give them a small reward afterwards. Our adolescents are going to be more focused on maintaining their privacy. So we need to make sure that we're explaining procedures to them, involving them in the plan of care, and then helping them to figure out what coping techniques will work well for them. Their overall reaction to hospitalization depends on a handful of things, most importantly, their age, how much preparation they were given, what their home life is like, if they've been hospitalized before and they have experience, and then their overall emotional health. Their main stressors are going to be separation, pain, and fear of body intrusion. So, hospitalization tends to bring out separation anxiety. Most often occurs in infants 6 months or older and is most pronounced in our toddlers. There's 3 stages of separation anxiety. The first one being protest, where they're screaming, they're inconsolable, they're yelling for mom and dad. Then we move to despair, where they all of a sudden stop crying, they're really down, they're withdrawn from everything, they don't want to play with anyone. This is a time when their security object is really helpful. Letting them have that security object and then slowly integrating them back into whatever everyone else is doing will help them move through that despair phase. Then finally, we have our denial or detachment phase, when parents return and the child completely ignores them. They're more concerned with what they're doing than their parents returning. And this is actually a coping mechanism to reduce the emotional pain of their parents leaving. We know that hospitalizations cause fear. There's fear of invasive procedures, fear of being separated. There's all these disruptions to the child's trust level, different people that they have to engage with. And then we're doing all these things to them that they can't make any decisions for themselves. So it causes a lot of fear. We need to encourage families to let us know those special things that they do and what their normal routines are and rituals are so that we can incorporate them into the hospitalization as much as possible. This will help to provide security and give the child a sense of normalcy. We also see regression in hospitalizations. So this is a loss of a previous or an achieved level of functioning and reverting back to a past level of behavior. So a child that typically drinks from a cup will demand to drink from a bottle, or a child that is fully capable of walking will want to be carried, things like that. So going backwards in their development. And this is all just due to the stress that the child is under. So we can minimize regression by doing an accurate nursing assessment of what they're able to do, and then making sure that we're encouraging those behaviors that we know that they can do. We should never punish a child for regression. It's just simply a way to cope with stress. So we need to guide parents to praise appropriate behavior and ignore those regressions. So we have our first critical thinking discussion. So we have the mom of a 2-year-old patient says she has decided not to visit for the next couple of days because it upsets her daughter too much when she has to leave. She says that it will be easier on everyone if she stays away until it's time for her daughter to be discharged. How should the nurse respond?
Allow the moms to stay?
Yeah, we want mom to stay. Absolutely.
I
How do you
think that
think?
she should. So sorry.
Go
I was
ahead.
just gonna say, I think that she should just like remind the mother that the bonding will be affected,
Mhm.
especially with longer periods of separation.
Yeah, so those long periods of separation can cause the child to feel abandoned. So we definitely don't want that to happen. What stage of separation anxiety is this child demonstrating? When she's
Despair?
crying. She's crying as soon as her mom leaves, making a real
Despair?
big scene.
Protest.
Protest.
Okay.
There we go. Yep, making a big scene, crying, that real dramatic behavior. That is our protest stage. So that's what mom's seeing when she leaves. So of course, mom's going to feel horrible that she's leaving her child in this state, but she's not seeing that the child will calm down and move on afterwards. So we need to provide that education of the whole spectrum and those supportive mechanisms of having mom there, having those short goodbye rituals, things to look forward to when mom comes back. All of those interventions can be really helpful when dealing with separation anxiety. But mom definitely needs to be there and not avoid her child. Okay, let's talk about pain. So pain is whatever the person experiencing it says it is. So we take them at their word. Whatever they say is what they're feeling. Sometimes our kids will be afraid to tell us that they're in pain because they're afraid we're going to give them an injection. So they might not tell us when they're hurting because they're scared they're going to get a shot if they tell us. We need to make sure that we're using the right pain scale for our children. And we're going to look at different scales that we can use based on their development, their language skills, and their age. So the first pain scale that we have is our FLAC scale. It's used in our 0 to 3-year-old and nonverbal children. We can also use the CRY scale or the NIPS scale for our infants and neonatal population. All three of these scales look at an observational assessment. So we don't need the child to tell us anything. We're just going to observe things about them and determine their pain according to our observations. So really easy way to assess pain. Next, we have our faces scale for our 3 to 8-year-olds. So you have them pick out whichever face most closely corresponds with their pain level. We can also use a poker chip scale that's very similar. So we give the child 4 poker chips and they give us back however many relate to their pain. So if they only give us 1, they're in a little bit of pain. If they give us all 4, they're in the worst pain of their life. So that's another one that we can use. In our kids that are 9 and older, we can use a number scale. Sometimes it helps to have the faces along with it so that they can quantitate it a little bit better. And then we also have an Oucher scale for our 3 to 12-year-olds. And that's very similar to our faces scale, but it has culturally specific photos with the associated pain scale. So some cultures may not express pain in the same way, so you might not see the same facial reactions. So these take the cultural considerations into play with the Oucher scale. When we're managing pain, we want to maximize all of our non-pharmacologic techniques. So things like drawing, distraction, imagery, relaxation, cognitive strategies. One of those is called thought stopping, where you have the child repeat stop in response to a negative thought until that thought goes away. And then massage is also very helpful. We know our pediatric patients respond very differently to medications. We know that their immature liver system will prolong the time that it takes them to excrete their medications. So we need to watch for those medication backups. Making sure that we're dosing our medications based on their weight and those differences in how they process medications. When we provide adequate pain relief, we allow our patients to focus on their surroundings and those normal activities of daily living. If we don't provide appropriate pain relief, it can cause the child to focus just on the pain and when the next medication is, and not be able to go on with normal activities of life. So when we do preventative pain control, where we're giving low doses of medication around the clock, whether they're in pain or not, we can continue to provide better pain relief and not have to use as much medication. So staying on top of it and assessing and treating the pain early will allow for those lower doses and that better pain control than if we would just wait until the child was in excruciating pain before we medicated. Some of our common medications, acetaminophen or Tylenol, is used for mild to moderate pain. We have our NSAIDs like ibuprofen that we can use. And then for opioids, we need to make sure that we're going to use those for more moderate to severe pain. Make sure that we have naloxone on hand in case of an overdose. For our short surgical procedures, fentanyl is going to be our drug of choice because it has a rapid onset and a short duration. So it's great for those short procedures. And then for our skin sutures, IVs, lumbar punctures, we can use topical anesthetics like Emla cream. So we just apply that to the skin and then it will provide some numbing capacity for that procedure. And we can use that all the way down to our neonatal population. So Emla can be used across the board. For conscious sedation, this is when we are giving IV medications so that a child won't remember a procedure, but they'll still have all of their protective reflexes. So they'll be able to maintain their airway, they'll be able to respond to stimuli, and do some basic movements for us. Anytime we have a patient under conscious sedation, we need to make sure that we are 1-to-1 nurse-patient ratio with them until their vitals return to normal, they're able to move independently, and they have that pre-sedation level of consciousness. When we're in the hospital, sometimes we need to use interpreters. to improve the communication between the parents and the healthcare team. So parents are going to understand medical information in their native language a lot better than if they're having to also try and figure out what it is in English. We don't want to use family members as translators because there's a risk of information being lost in translation. So healthcare sites are required by law to provide interpreters to the family at no charge. So make sure that you're using this resource. Also talking about communication, there are different intercultural responses to hospitalization. So we need to know what is appropriate for each culture, what they're expecting, what's acceptable, both verbal and nonverbal communication. And we need to take the time to become familiar with the different cultures that we will experience. And showing that cultural sensitivity is going to decrease the patient's anxiety. So some nonverbal things that we need to watch out for. We need to look at personal space. How close is too close? How far is too far? What is your personal bubble? Also, smiling is perceived very differently in cultures. Sometimes it's perceived as being very friendly. Sometimes, like in Russian cultures, if you smile during a serious situation, it's considered inappropriate. So you're minimizing what the child's going through. We need to look at things like eye contact, whether or not it's appropriate to have direct eye contact with somebody or if it's more appropriate to look away. And then touch can also give very misleading messages. So we need to make sure that we are asking permission before we ever touch a patient. So sometimes things like patting somebody on the head could indicate superiority, or could even be as bad as robbing the patient of their soul. So you need to be very cautious of touching a patient. And then focus. So cultures perceive and have a different focus on hospitalizations, illnesses. Some people are going to focus directly on the problem. Some cultures are going to deal with the future impact of the family or the life of the child is going to be more their priority. Parents also have very wide reactions to hospitalizations. They may ventilate their fears through stress. They may be very angry. They may be very emotional. They may be withdrawn. Their reactions are across the board. So we need to remember that their behavior is going to be a combination of their ability to deal with their child's current situation, as well as any past experiences that they've had with the hospital system. So if they had a bad experience as a child and now their child is in the hospital, they're going to transfer that bad experience that they had onto their child and automatically come in thinking the worst thing is going to happen. So we need to be very understanding and accepting of people and the problems that they bring with them into the hospital. We need to make sure that we're communicating effectively and clearly so that we're not causing any unnecessary fear. Our role in the hospital admission process is to be prepared to meet the needs of the people involved. So asking a lot of questions so that we can anticipate their needs. We should encourage parents to be as matter of fact as possible when they're trying to explain things to their children. It's not necessary to go into a bunch of detail with their child because that just makes them more anxious. Hospitalizations are overall very frustrating for parents, for children, for nurses. The child might miss being with their parents, especially if they have another sibling and parents have to be home with the sibling. So they might miss some of that interaction. Their daily schedules are completely disrupted. So our goal is to try and maintain that relationship between the parent and the child as much as we can, and then promote those sensory motor activities. So rocking, talking, cuddling, bathing, using a mobile, singing, all of those things that engage the senses. And then we have very liberal visiting hours to make sure that we don't disrupt that bond between the parent and the child. So most children's hospitals are going to allow parents to be at the bedside 24/7. They can come and go as they please. And then we really want to encourage that consistency in caregivers to build that good, trusting relationship. When we're looking at our adolescents, they have a good understanding of what is going on with their disease process. So at this point, they're able to process the information that we're telling them and be involved in their care. So we need to allow them to participate and really encourage them to make their own decisions and be an active participant in their care. So our next question here, we have an 8-year-old boy admitted to the pediatric oncology unit for his first round of chemotherapy. While the family is visiting, the nurse observes the patient's 4-year-old sister crying and repeatedly asking her parents to give her a bandage for her owie. The mother tells the child she's fine and to stop crying so that she doesn't disturb the other patients. What does the child's behavior suggest, and how does it affect the patient's nursing care plan? What do you guys think?
Child wants to feel included.
Absolutely. Sister's feeling excluded.
Mm-hmm.
What should we do to help that?
It won't hurt to just give the child what she wants.
Yeah, we can give her a Band-Aid for her owie. What other things could we do that help her feel more involved in the situation?
Maybe let the 4-year-old touch some things around there that are safe enough.
Yeah, let her play with the equipment along with her brother. You can give her a task to do. I mean, as simple as if you've got supplies laying out, let her gather supplies for you. Let her grab things for you so that she feels included and part of the family dynamic. We also want to encourage the parents to try and give her some individualized attention. She's probably feeling like she's not getting the attention she's used to, that she's being left out. That's really important for her. And then we can also use our support services like social work, child life, to help both parents and the younger sibling deal with brother's hospitalization. When we're looking at roommates, we want to pay attention and try and pair our peers together so that they're in the same developmental stages. They're going to be doing the same types of things, making sure that we're not pairing an adolescent with an infant or a senile person, where you're not having that good dynamic between them. Adolescents will usually do better when they have roommates so that they have that socialization that they're looking for during that time of life. And then we also need to make sure that we're considering the disease process. So making sure that we're not pairing an immunocompromised patient with a patient that's on contact isolation. Probably not going to be a good mix. So making sure that we're considering both their development and their disease process when we're trying to pick roommates. For confidentiality and legality, we need to pay attention to those emancipated minors. So these are children that are no longer under their parents' authorities. They're going to be younger than 18, but have legal documentation stating that they're able to consent for themselves. Married minors and minors in the military are automatically considered emancipated and can give consent for themselves. Each state is a little bit different in the amount of information that we're able to disclose on adolescent patients. So make sure that you pay particular attention to what you're allowed to disclose to parents and what you need the child's permission to disclose to parents. So typically, sexually transmitted infections, contraception, pregnancy, and drug abuse all fall under that potentially protected information. So making sure that we're double checking before we release any information. When we're preparing for discharge, we need to start that as soon as the patient is admitted to the hospital. There's so many opportunities for education. And if we give it all right before we send them out the door, they're not going to remember any of it. We need to make sure that any home treatments or medications that the parents are giving, that they have written instructions, because they're not always going to remember what we tell them. And then ample time to practice so they feel comfortable doing any procedures at home. We also need to be prepared for behavioral problems that happen after hospitalization. So we can see those regressions that we see in the hospital. We can also see a lot of behavioral issues just because of the disruption in their life. So the best thing for parents to do is to integrate that child back into their normal routine and back into the family as quickly as possible when they're home. And then just provide that education to them so that they can be prepared for what to expect. When we are charting a discharge, we need to include who accompanied the child and the fact that we verified their identity, the time of the discharge, the behavior and condition of the child, how we sent them home, vital signs, their weight, their medications, and any instructions that we gave to the parents. So we want to create this nice little snapshot at discharge so that if we ever get audited for anything, we have that picture perfect, nice, neat little bow of what the child looked like when they left. So it's just a way to protect yourself. Some of our kids will go home with home health care. So our children with either an acute or chronic condition that need extra medical attention, but not sick enough to stay in the hospital. So that's where our home health care agencies and community agencies will come in and work with the family. They can also provide respite care for primary caregivers. So a child that requires 24/7 supervision. And this allows the parents to be able to run errands or to simply just have a retreat away from being a caregiver 24/7. So respite care is available for those patients with chronic condition. And very last question for you. We have a 16-year-old high school junior and varsity athlete that's admitted to the pediatric unit after a car accident. She has a head and facial lacerations and a fractured femur. During the initial nursing assessment, she avoids eye contact during the conversation and is withdrawn. She also says that her junior year has been ruined and she cannot possibly go to the prom looking like this. What developmental concerns influence her recovery, and how can she be included in the nursing care plan?
She probably don't think she gonna be cute anymore because of the scars on her face.
Yep, her physical appearance is going to be a big problem. Not only does she have scars on her face, but now she's got a cast on her leg because she's fractured her leg. What else? What about being a varsity athlete?
Probably feels like her career is over.
Yeah. Yep. So if she planned on doing sports in college, she might be afraid that that dream has completely sailed.
I think that, like, obviously something needs to be implemented to, like, help her cope and express her feelings.
Definitely. What other things can we do to encourage her during this time?
Get her involved in support groups with other children or teenagers, that's going through the same similarities.
Yeah. Yeah. What about visitors?
Encourage her to invite her friends to visit.
Absolutely. Visits from her teammates, her coaches, her friends could all provide that extra support for her that she is going to need during this time. Give her a connection back to school and her normal social environment. So all of those things are going to be really helpful in helping her adjust to being stuck in the hospital. It's very good job, guys. We will go ahead and move on to our Kahoot. That's all that we have for our PowerPoint. So if you guys want to get your Kahoots ready, I will pull that up. Okay, guys, we're gonna go ahead and get started. The pin is in the chat if you guys need to join later. Okay. Which child would have the most difficulty in coping with separation from the parents? And that's going to be our 16-month-old. So remember, separation anxiety is starts at 6 months and peaks at our toddler age, so our 2 and 3-year-olds. You can decrease the stress and anxiety of a 2-year-old in the hospital by keeping their regular home schedule. So giving them that normal schedule that they're used to so they can anticipate what's going to happen next. You ask a child to draw a picture about a scary hospital procedure. We're providing a way for them to express their feelings. So, a lot of times, our younger children, especially, can't verbalize what's going on inside their heads. So, they might be able to draw it and explain it a little bit better that way, or at least clue you in to what they're thinking. We have a 2-year-old crying constantly for his mother since he was hospitalized 3 days ago. This is a child that is stuck in that protest stage of separation anxiety. And at this point is starting to feel abandoned by his mother. Which statement best corresponds to a preschooler's understanding of hospitalization? And that is, I got sick because I was mad at my brother. So if you remember, our preschoolers aren't able to understand, they don't have the logical thinking to understand a hospitalization. They see that as a form of punishment. So they think they did something bad. So my parents sent me to the hospital. So they got sick because they were mad at their brother. Toddler seems more interested in her toys than the parents. What stage of separation anxiety? And that is the denial or detachment phase. So when the parents return, the child is busy playing and doesn't want anything to do with the parents. That's that last phase. So we need to work with the parent and the child to help reestablish that relationship. Selecting a roommate for a 16-year-old with cystic fibrosis. So we need to find a peer that's not going to cause any infectious processes. So our best choice here is going to be a 15-year-old, so similar age, with type 1 diabetes, because your cystic fibrosis patient is going to be at risk for contracting infections really easily. So a diabetic is going to be a pretty safe roommate choice there. Parents of a hospitalized 9-month-old ask if their preschool child may visit his younger sibling. So we need to encourage that. Preschoolers need to visit their siblings to reassure themselves that they're okay. So even though we might tell them that their sibling is okay, until they lay eyes on them themselves, they're going to have a hard time understanding that. Everybody double check your cameras. We got a couple people off camera here. Hospitalized toddler was drinking from a cup at home, but now refuses to drink anything but from his favorite bottle. So that is a regression and a way of dealing with anxiety. So when we know that they're capable of doing something and they refuse to do it, but act younger than their age, that is a regression. Nurse encourages a school-age child to draw a picture after a painful procedure, and that gives them a way to express their feelings. Also can distract them from thinking about the pain, so double-edged there. When is the best time to begin to prepare a 5-year-old child for surgery and hospitalization? And that's going to be about 4 days ahead of time. So we don't want to go as far out as 2 weeks because they're going to forget everything that we've told them. So keeping it somewhat close to the hospitalization, but also giving them some extra time to be able to process, think about their feelings, be able to ask a lot of questions. So that 4-day mark is a good window. A 13-year-old girl has been hospitalized for the past week. What is the girl's biggest concern? And that is going to be her appearance. So remember that those teens, early teens, are going to be all concerned about their appearance. The nurse notices the mother of a child with CP redoes many of the things that the nurse does. What's the best response to the mother? So you'll notice this a lot in the hospital with children with chronic conditions. The parents have a very specific way that they do things and they like things done. So if you don't do it that way, they're likely going to redo everything that you've done. So the best way to relieve the tension in that situation is encouraging the mom to share those special things that she does for her child or any particulars about the way that she wants it done so that you don't have that constant back and forth. Surprise when I visit, maybe I should just stay away. What is the nurse's best response? And that is providing that education. This is a common reaction when they're separated from their parents. So that separation anxiety education for them all. Russian cultures, it is inappropriate to smile during a serious situation. So if we're interacting with a Russian family, then we need to make sure that we are keeping a straight face when we're engaged with them so that we're conveying the appropriate amount of regard for their child's condition. What nursing action would facilitate rapport with the child and the child's parents during the admission process? And that is to answer questions in a calm, matter-of-fact way. So making sure that we're providing answers to all of the parents' questions and we're just maintaining that calm demeanor to help them to bring down their anxiety. Remember, our toddlers and our early school agers are afraid of bodily harm or those invasive procedures. So that explains why the child starts crying as soon as it's time for his operation. How does a preschooler understand the reason for being hospitalized? So again, this is where they see hospitalization as a form of punishment. So they think their appendix got sick because they hit their sister. We're looking here again for that separation anxiety age range. So an 18-month-old is going to be our best choice here. How do you know the parent understands a hospitalized toddler's need for transitional objects? So the correct answer is the stuffed animal makes him feel secure. The answer that says he insisted on bringing this dirty old blanket with him, yes, they're acknowledging that transitional object, but they're lacking the understanding of its purpose. So, not understanding that it makes the child feel secure is why that one's not right. You tell time with a preschooler. You use those things that they're very familiar with, like meal times, nap time, TV shows. So saying dad's coming home or dad will be here after lunchtime. Fentanyl is our drug of choice for procedures because it has that rapid onset and the short duration. Keyword here is interdisciplinary. So when we're looking at all of the information, the timelines for every single person involved in the patient's care, that's going to be a clinical pathway. Your comprehensive nursing care plan is going to be your nursing interventions alone. It's not going to encompass things from nutrition, from your physicians, from social work. That's not going to be included where it would be in a clinical pathway. Adolescents have to be cognitively aware, so competent, and over 18 to be able to sign their own consent, or they have to be an emancipated minor to be able to consent for themselves. Legal guardians and healthcare guardians are people that are assigned to consent for somebody, but not consenting for themselves. Starting an IV on an infant, we want to involve the parents as much as possible. Give them that safe person. Stages of separation anxiety, we start with protest, with that loud outburst when parents leave. Then we move into despair where we're sad and we don't want to play anymore. And then we finally move into denial or detachment where we're ignoring our parents when they come back. Remember, when we discharge a patient, we want to wrap everything up in that nice, neat little bow and have that good snapshot of the overall condition of the patient. So we're going to want to make sure that we document all of these things. What we're telling the physician, well, one, we're probably not gonna be giving instructions to the physician at discharge. They're gonna be completely signed off on the patient. And two, we're not concerned with what we told the physician, we're concerned with what we've told the parents. Separation, pain, and body intrusion are the basic fears of our hospitalized children. Last one. Caring for a toddler, we have to make sure that we're doing that therapeutic care where we're making sure that we're meeting all of their developmental needs. We most definitely have to be flexible. They're never going to do exactly what we want, the way that we want them to do it on the timeline that we have in mind. So we have to be very flexible. And then we need to use soothing techniques when teaching them about scary experiences. So let's see who our winner was this week. Okay,